We are in Warwick Hospital here, and we have so many wonderful acute hospitals around. You and I want them to survive, but truthfully, do you really think if we don't get dementia care right in hospitals, do you think they will survive? And I'll tell you why. But please, please, when you go home, try to look up this report by the Royal College of Physicians. It is titled Our Hospitals on the Edge. And what it says, if we don't improve, if we don't look after our patients in a different way, in my mind, if we don't get the dementia care right, that will not only cause problems to our beloved Warwick Hospital, but to all the acute hospitals, to all the NHS. The whole system could collapse. And this is what you will read in this report. Before I go into it, just look at this. You see what is happening there? This is the life cycle, right? You can straight away when you see it, it's a kind of Victorian kind of drawing, but you see child, a lad, messing about, teenager feeling proud, developing your career, pushing the old man off the top of the ladder. You feel you're all made. What happens after that? We start decline and we end up just sitting in a chair in the old home. This is the traditional way of looking at aging. This is what all of us fear. But you know, this generation, what they want? This is how they see aging. But apart from the joke, the serious point of it, older people now are expecting a lot. They don't expect to end up in a nursing home in a chair. They want to have active aging. They want to be involved in their care plan. They want to design things for the future. They are not going just to accept the previous image of aging. You know why the whole system would collapse if we don't do something? Helen, how many patients you have here? How many beds?
About 400.
400. You know what that means? 2/3 of them are elderly. So today we'll have something like 250, 270 elderly people in this hospital. Probably more than that. Half of them will have dementia or related disorders. We have filled from the QE 1,200 beds. 900 of them are elderly. And about 450 of them every day are people with dementia who came to the acute hospital, not because of the dementia, but because of other things. And they want somebody to look after the dementia there. But the thing is, the vast majority of them are not known to have dementia before they came to the hospital, not even referred to psychiatric services. And you know, if we don't do that, guess what happens? Helen, as one of the execs, will have figures every day about length of stay. And not only as a KPI, but truthfully as a clinician, the longer length of stay leads to a lot of problems. We want to shorten it. That's the right thing from economical point of view, but also from care point of view. What is happening to length of stay in the country? In general, is it going up or down? It's going down. Absolutely significantly down. Think of hernia operation many years ago. A week admission. Today, it's a day surgery. Think of cesarean section. It was 10 days admission. Now, 48 hours, if that, and the patient's out. With the exception of the elderly. Once he hit the 75 age, the length of stay increases. With it, increased infection, increased falls, increased mortality, everything the acute hospital exec will try to get their head around saying what is going on. And that all happens with age. Right. The 3Ds is the big problem we have. Dementia, delirium, and depression. If you are in Mid Staffordshire Hospital, you'll be thinking of dignity as well as a problem. But anyway, we are in Warwick. But you see, my point is, if people have dementia, length of stay will be increased, readmissions increased, mortality increased, falls increased, infection increased, complaints increased, unsatisfaction increased, everything. And then you have to deal with this whole lot because we haven't dealt with the dementia question. Right. I would really love one of you guys, or I'm hoping one of our junior doctors will repeat this, but the Alzheimer's Society a few years ago did a fantastic piece of work. They went into all the wards, asked the nurses, what do you think of dementia? What did the nurses tell them? What is dementia? We never had training, we don't know what dementia is, don't have time for those patients. And just to give you an idea, can anybody tell me what's the average length of training an average nurse will have before graduation on dementia? Keeping in mind, they will spend 2/3 of their time possibly dealing with older people with dementia. Anybody wants to guess? In a 3 years course, how much will have? Madeleine is spot on. It is actually the average is an hour. An hour on dementia, and then the nurse off to the wards. This is why we have Phil trying to work in the QE, putting extra training in. And this is why, if you ask the families will tell you what about patients with dementia. They say they become more confused, they pick up infection, they have more falls, they lose weight. Basically, if you have dementia and you come to the hospital, there's a chance you just leave the hospital a little bit frailer, a little bit worse than they came with. This is what's happening in the system. But if we work together, if we bring geriatric medicine with old age psychiatry, with psychiatric nursing, general nursing, social worker, the whole system comes together. In the hip fracture study, there's a reduction of 2 days in length of stay. 2 days in terms of money, this is a lot. In terms of quality of care, this is the right direction. Again, another study from the Netherlands did the same thing, and length of stay goes down by 5 days. This is just the right thing to do. And I'll tell you more about trade in a few minutes. You see what's happening in the community? And please, challenge me if I'm wrong. If I'm just exaggerating, scandaling things, just stop me there. Patients with dementia go to GPs. We know 50% of the GPs tells us we don't have experience with dementia. They don't want to diagnose dementia because you don't know what to do next. The patient develops infection. They come to the hospital. We don't have much records. We treat the infection or we manage the fall. You find them confused. What you do? You admit them. You admit them, they become more confused. We try to do something, charge them to care home, and then we send it back to the GP. The same story happens over and over again. I'm exaggerating a bit, but not too much. And if you think it's different, please tell me. And just to prove the point, this is from Dudley, hasn't even been published yet. What Dr. Michael did, he looked into over 1,000 patients came to the hospital with no diagnosis of dementia, unknown diagnosis of dementia, or diagnosed dementia is unknown. And what he did, he examined them. And 42% of them actually had dementia. Obviously, that's 42% of people coming to the hospital with confusion, without a diagnosis, have dementia. But you need to ask yourself quickly, what was happening before they came in? Right. Guys, raid in Birmingham, just in a couple of minutes. What we did, we create 24-hour, 7 days a week team, dealing with all the problems in the hospital, 1 hour target to the NDE, 24 hours target to the wards, seeing people quickly. And what happens? And this is what the message I want to give all of you. We see about 1,400 new patients in the whole of Birmingham and Solihull every month. Only 20% of them come our way, have dementia, right? But I will show you the surprise. We see patients within 23 minutes in the A&E, within 16 hours on the wards. We looked at the savings. We reduced the length of stay. We increased avoiding admissions at the A&E. We reduced readmissions, and we saved, on the best case scenario, 66 beds per day. 80% of them come from dementia patients. And on a worst estimation, we save 49 beds, 80% of them come from dementia. 20% of the referrals, 80% of the benefit. And when we did that, City Hospital removed 60 beds, and not only that, we were able to discharge more older people to their homes rather than to care homes. On that, we saved about £60,000 a week to Birmingham City Council. All these savings that has been verified by the London School of Economics, we said, if you spend £1 in this way, we'll return to you £4. This is independent evaluation showing actually we reduce, by doing that work, you reduce admissions from the A&E, you save around £1 million, you reduce length of stay to the wards, you save about £1.6 million to the commissioners, £5.3 million to the providers, and in the whole of Birmingham and Solihull, every pound spent, we returned back £2.98. And if you look at this, this is where I want to get the message to you. That's the CSU work. And they looked at all the hospitals in Birmingham and Solihull. Admissions from A&E went down in all the hospitals except Solihull. You know why? In Solihull, they closed the A&E department at 8 o'clock. See, if you have an elderly person with confusion coming at 3 o'clock or 4 o'clock, you know you are not going to sort it out. What do? You admit them. In the QE, we have friends there, the length of stay in all the hospitals went down with the exception of the QE, because the rate team were asked to put all the resources on the front door, work with the younger people, leave the people with dementia for now. Effect on length of stay was what? 0. No effect at all. And this is why in HEFT, every pound spent working with patients with dementia as well as young people, we returned £5. In the QE, the rate team, every pound spent, they lost £1.07. Outside Birmingham, the same story. In Pennine, they saved £3.3 million. In Wigan, they had a more focus on younger people and they saved only £2 million. So where's the problem then? We have a lot, but the problem is our care is disconnected. People tend to come to us at the worst point of the system, which is A&E. We need to work before that. My data system doesn't talk to the QE data system or to the HEFT data system. Everybody has different data system. Inadequate monitoring for the system. Patients and families are still detached from the way we try to change the system. And also we spend most of our time, which I'm sure Helen will agree with me, fighting with problems happening around us, rather than try to avoid the problem. Right. Dementia sequence, I hope you get this in your head because that is something important happening. And with being integrated, you see this is the kind of sequence we return. In HEFT, I have a memory clinic in the acute hospital, and now we work with the Alzheimer's Society. Well, guess what? For free, they provide for us carer support, information, Alzheimer's cafe, everything in the acute hospital, not in the mental health trust. We use a lot of innovation, like the reminiscence pod. And I have so many stories, but we have reminiscence pod, changing the environment. I had a patient who refused to be in the hospital because his wife died in the same hospital. And he wanted to leave really, really poorly. Should I section him? Should I tie him down to the bed? Should I shout at him? Should I drug him with haloperidol? We shouldn't do any of that. What we did, we put the reminiscence pod and the whole atmosphere changed. The guy was eating, drinking, talking with his family, had his care and improved. Also, we use My Life software on a couple of wards. You get the patients to choose the reminiscence materials, songs, soaps, football. It's all from the right time, and just change the atmosphere in the ward. And the nurses find it useful tool to communicate with the patient. And Phil is part of this as well. We're developing dementia training material, and this is e-learning module using proper actors and some of our nurses to give online training for the nurses on dementia. So we're doing some work, but believe me, it is a whole arena of work still waiting for us to be done. If we work together, we get it right, we'll not only prove quality for our patients, we'll save the NHS. If we don't get it right, I promise you, financial problems will be harder, quality will be less, complaints will be more, and our satisfaction with our jobs will be even less. Thank you so much. Thank you.